Hello friends, today we are going to discuss about cognitive behavioral therapy for insomnia. I am Dr. Suresh Badadmat, Professor of Psychiatry, working at National Institute of Mental Health and Neurosciences, Bangalore. In this video, I'll be discussing about insomnia, what is the prevalence, what are the components of cognitive behavioral therapy for insomnia, and the process of doing cognitive behavioral therapy. Insomnia. Chronic insomnia is associated with substantial impairment in quality of life, loss of functioning, loss of economy to the society, and also increased health risk for the person. It can also be a risk factor or a triggering factor for mental health illnesses or medical illnesses. Insomnia is based both on the perception of the sleep, that is the quality of sleep, the subjective feeling whether I slept very well or not, and also decreased sleep. Actually, the duration of sleep has decreased. That is the quantity of sleep. So, the both quantity and quality of sleep needs to be assessed. Research guideline emphasizes the assessment of both subjective and objective measures to be done. The objective measures are done by polysomnography or actigraphy. The subjective one, the patient will be reporting by diary and also telling how much he feels that he has improved. Now the question is, what is insomnia? Is it just a simple jet lag? Or else you have gone to a new place, unable to sleep? Is it exam-related stress? Or is this insomnia an illness? That we need to define. Let's look at the diagnostic criteria for insomnia. If you look at the DSM-5, it clearly says the first and the foremost, dissatisfaction with sleep quantity or quality with following one of the criteria. That is, difficulty in initiating sleep, or difficulty in maintaining sleep, or early morning awakening. Either one of them should be there. The next criteria is the sleep disturbance causes significant distress or impairment in daytime functioning, as evidenced by at least one of them. Low energy or fatigue, daytime sleepiness, impaired attention, concentration or memory, mood disturbance, behavioral difficulties, impaired occupational or academic function, impaired interpersonal or social functioning, negative effect on caregivers, or family functioning. This sleep difficulty occurs at least 3 nights per week over a period of at least 3 months, then we call it as chronic insomnia. So, my dear friends, we need to understand there can be acute insomnia less than 1 month, subchronic insomnia between 1 to 3 months, persistent or chronic insomnia is more than 3 months. This insomnia can be secondary to psychiatric disorder. For example, patient with bipolar affective disorder can also have insomnia, or else patient with depression can have early morning insomnia. Similarly, a person diagnosed to have cancer, that is medical illness, can also have insomnia, or any other reasons for insomnia. It can be related to new place or stress. So these are the various specifiers mentioned under DSM-5. But however, we need to look into the international classification of sleep disorders. In this, insomnia has been given three important criteria. The first criteria is one or more of the following symptoms should be there: difficulty in initiating sleep, difficulty in maintaining sleep, waking up too early, and the fourth one is non-restorative sleep, that is poor quality of sleep. B is very essential. Sleep difficulty occurs despite adequate opportunity for sleep is given. This is to rule out if a person is doing night duty for long duration, he is not getting adequate time for sleep. So such kind of job related sleep problems to be eliminated. Hence, this criteria has been placed. C, at least one of the following daytime symptoms related to night sleep difficulty should be reported: fatigue, poor attention and concentration and memory difficulty, social occupational dysfunction, academic dysfunction, mood disturbance or irritability, daytime sleepiness, motivation or energy reduction, proneness for errors or accidents, tension headache, gastrointestinal symptoms or both, and also worries about sleep. So these are the criteria have been given. Now let's look into the prevalence of insomnia. Insomnia is characterized by perceived difficulty of initiating or maintaining sleep, which turn has a negative influence on daytime functioning. Further, reports on the prevalence of insomnia is variable based upon the time of the study, in which population you are doing, is it in a disaster prone area, what is the age of the person, is it urban, rural, is it on children, adult. So based upon the various parameters, the prevalence varies. 1/3 of the adult population, that is, imagine 30 to 40%, display at least one symptoms of insomnia, while 6% meet the diagnostic criteria of insomnia, which I discussed shortly. In this, you need to understand, the insomnia does not require EEG or any other lab investigation. It's more of subjective reporting of not able to sleep or poor quality of sleep, perceived difficulty in initiating, maintaining, or early morning awakening. So this is the criteria which has been used, and also in epidemiological study that has been concurred. If you look at the acute insomnia, 1 in 3 people, that means 30 to 35% have at least one symptom of insomnia, that is acute insomnia. 75% of the adults above the age of 65, that is basically senior citizens, have insomnia. Similarly, 43% of the preteens have insomnia. If you look at the chronic insomnia, that is more than 3 months, 10% of them have, that is 1 in 10. So my dear friends, the prevalence of insomnia is very high. It is to that extent, it is becoming a public health concern at this point of time. We need to understand that insomnia causes not only the health risks to the person, loss of productivity to the society and the family needs to be taken into consideration. Along with, the person who has insomnia may meet with an accident, can be dangerous to others because of his insomnia and related problems when driving the vehicle. Now let's look into the treatment of insomnia. In the real world, it is different. In the ideal world, it is different. Let's discuss about the ideal world. If you take any of the treatment guidelines in the developed world, either in US, UK, European countries, Canada, Australia, the first line of treatment is cognitive behavioral therapy for insomnia. But unfortunately, even in US, UK, access to cognitive behavioral therapy is very limited. For simple reason, the people who have been trained to provide cognitive behavioral therapy are limited. In India, we have hardly 3,000 psychotherapists who have been trained to provide cognitive behavioral therapy in insomnia. That means if you are looking at 10% of the population is having chronic insomnia, that is 15 crore people need to be treated by 3,000 psychotherapists. That means it's simply impossible to provide care. Hence, what happens? In the real world, the first line of treatment is medication. The benzodiazepines, or it can be antipsychotics, or else any sleep-inducing pills will be given. Unfortunately, many a time, the primary care doctors, general physicians use irrational prescription and widespread misuse of benzodiazepine is occurring. Many general practitioners, primary care doctors, nurses receive inadequate training in sleep medicine and also in cognitive behavioral therapy for insomnia. It's not only with them, even for the psychotherapist. They do not have been given training in sleep medicine or else in cognitive behavioral therapy for insomnia. In this regard, there is a poor access to cognitive behavioral therapy in real world. Hence, there is a widespread use of sleeping pills. Not only use, but also misuse is occurring. If you look at the literature, it causes serious public health crisis. Insomnia and its effect on the society and also on the economic front. Further, excessive use of sleeping pills, misuse, dependency on sleeping pills is causing grievous public health concern at this point of time. An interesting publication came from Psychiatric Services in 2019. Donovan and his colleagues published an article titled as Benzodiazepine Use and Misuse Among Adults in United States. They clearly called it as a public health crisis. They did a cross-sectional analysis which was conducted between 2015 and 2016, National Survey on Drug Use and Health Data for Adults. The number of people were surveyed was 86,186 adults. And data from these respondents reported benzodiazepine use in 10,219. Measurements included past year prescription of benzodiazepine use, misuse, substance use disorders, mental illness, and other demographic details were collected. The results were stunning. 31 million adults reported of using benzodiazepines. That is 13%, my dear friends. 25 million were prescribed sleeping pills in the past 1 year. That is 10%. 6 million, that is 3%, misused. Without prescription, they got the sleeping pills. That is benzodiazepine. If you look at the age and benzodiazepine usage, adults, that is from the age between 15 to 64, had the highest prescription rate, that is 13%. The teens or the young youths, 18 to 25, had the highest misuse, 5%. And those more than 65 had 0.6% of usage. By looking at this, sleeping pills has becoming a public health concern in US. Further, the benzodiazepines are not used alone. Alcohol use, opioid use, in combination with benzodiazepine is causing a great concern. Especially in geriatrics or senior citizen, benzodiazepine uses can cause orthostatic hypotension or giddiness, resulting in fractures. That means they will fall down. And this femur fracture is becoming a big problem everywhere. All these factors have clearly indicated cognitive behavioral therapy for insomnia as a first line of treatment. But access to treatment of cognitive behavioral therapy is very poor, not only in India, but also in developed countries. One of my friend in US said that the waiting period for cognitive behavioral therapy for insomnia is somewhere around 8 to 12 months for in-person CBT. If that is the condition in US, think about in India. Now let's look into the model of insomnia. There is a multidimensional approach has been given. If you look at this diagram, you can clearly understand. First and the foremost, the maladaptive habits, excessive time spent in the bed, being awake, irregular sleep habits, daytime sleeping, watching mobile phone, social media, internet, inappropriate use of benzodiazepine. These are maladaptive habits. Further, beliefs and attitudes such as becoming worried about sleep, rumination over the consequences of not having adequate sleep, unrealistic expectation, misattribution and amplification with regard to belief. This leads to emotional fear, sadness, cognitive bias, physiological arousal. This leads to insomnia, further causing fatigue, poor performance at work, mood disturbance, and social discomfort. So it's not single cause. There are multiple causes which leads to a vicious cycle and becoming insomnia, a chronic disorder. Now let's look into the classification based on onset. Here you can see on one end the depth of the sleep. At the top is the wake. As you go down, you can see REM sleep, stage 1 sleep, stage 2, and slow wave. That is the deepest sleep. On the other end, you can see the time. As soon as the person goes to sleep, there, the time taken to go into sleep is called as sleep latency. In between, the person is awakening. That is middle insomnia. In the last, you can see early morning awakening. So this is how we can understand difficulty in getting sleep, unable to maintain sleep, that is fragmentation of sleep, and finally early morning awakening from sleep. So these classification you need to understand. That's the way you'll be able to know what kind of sleep problem the person has. Now let's further understand. You can see at the bottom the time, that is from 10 p.m. to 6 a.m. The person is able to sleep adequately for 8 hours. That is called as normal sleep. In some people, they have difficulty in falling asleep. So this is very common. Next one is break in sleep. That is fragmentation of sleep. He is not getting sleep continuously. In between, he is woken for various reasons. The last one is early morning awakening. That is, he gets up at 4 o'clock in the morning. So here the green indicates sleep, yellow indicates awake and arousal. So these are the three important classification we know. But however, in single patient, the combination of these sleep problems can occur. And the same patient may have difficulty in falling asleep for 2 months, and after some time he develops early morning awakening, and sometime he may also have fragmentation of sleep. So it is not purely in one. The combination is very common. But also you need to know the sleep and recommended number of hours of sleep to be required as per the age. The newborn requires up to 17 hours of sleep. If you look at the preschooler, he requires around 13 hours. Young adults requires 7 to 9 hours. Adult requires 7 to 9 hours, and seniors will also require around 6 to 7 hours, because as the age picks up, the sleep decreases. Let's understand about the insomnia based on the type. As I earlier mentioned, difficulty in falling asleep, difficulty in maintaining sleep, early morning awakening, poor quality of sleep. If you look at the duration, transient or short-term insomnia, another one is chronic insomnia. And finally, which is a very old but worth knowing, primary insomnia and secondary insomnia. If there is no cause is there, then we call it as primary insomnia. If there is a secondary cause, it may be because of cancer is developed insomnia, or else because of anxiety disorder has developed insomnia, or else because of drug abuse has developed insomnia. So these are the various primary and secondary can be understood. But let's understand secondary insomnia. Again, it can be classified into because of medical condition, because of mental illness, and the third one is because of other contributing conditions. If you look at the medical condition, pain, reflux, metabolic issues, diabetes, they have to go for frequent urination, Alzheimer's disease, Parkinson's disease. In mental illness, substance use, anxiety disorder, bipolar affective disorder, and various other disorders. With regard to others, drug abuse, steroid, bronchodilators, over-the-counter medication, cannabis, nicotine can cause. So these are the secondary causes of insomnia. There is also another called as P3 model. What is P3 model? P3 model is predisposing, precipitating, perpetuating condition. Let's understand slightly. In predisposing, precipitating, and perpetuating, predisposing is, it is the personality or the arousal, anxiety predisposition are considered as predisposing, or else even genetic factors. The precipitating factor is stress, and the perpetuating factor is the person is unable to sleep in the night, so he sleeps in the daytime. So all these three factors play a role in continuation of having chronic insomnia. Let me repeat. Predisposing factors are genetics and personality, which is there as a biological, which are difficult to change many a time. Factors that are responsible for triggering, they're all stressors. It can be exam, death in the family, or else school-related issues or interpersonal relations related issues. Perpetuating factors that turns the insomnia into chronic insomnia. That is, the person's bad habit of using stimuli in the evening, smoking before sleeping, watching television for longer duration, or social media can cause perpetuating factors. So you can clearly see the predisposing factors, precipitating factors, and perpetuating factor. Now let's look at the principles of cognitive behavioral therapy for insomnia. Cognitive behavioral therapy is basically a behavioral treatment in the majority way, and to some extent cognitive component also is there. Here the participants are asked to make counterintuitive changes to their sleep patterns which they have developed. Here the sleep patterns are unhealthy habit which is causing chronic insomnia. Hence, the foundation principles of CBT I are called sleep restriction stimulus control. I'll be discussing them shortly. These techniques have been shown to have a dramatic impact on the quantity and the quality of sleep. And this can be delivered at least 1 to 2 session to 6 to 8 session by a primary care doctor, or even a nurse can provide cognitive behavioral therapy for insomnia. So in this process, the person need to learn that associating the thoughts with the good behavior, unlearn the bad behavior, or may be called as maladaptive behavior, and relearn the healthy sleep pattern that is causing new association. Let me discuss this in short while. Before that, if you do cognitive behavioral therapy for insomnia, we need to do a thorough assessment to know whether it is a primary insomnia or else a secondary insomnia. If the person has secondary insomnia, we need to treat both the primary cause of illness and also the insomnia need to be treated. Let's look at the assessment. First and the foremost, you need to look for the insomnia complaint. That is symptoms. Is it difficulty in falling asleep, or else maintaining the sleep, or else early morning awakening and quality of sleep? Was it a gradual? Was it abrupt? Was it a stressor is there or not? What is the duration of this insomnia? Look, ask for the severity. How much it is affecting the day-to-day functioning, social functioning, and biological functioning. Whether the course is acute, episodic, or continuous. Is there any precipitating factor and a perpetuating factor? Previous treatment and their response need to be asked. Further, pre-sleep condition needs to be known. Bedroom environment, psychological state before bedtime, sleep-wake schedule, wake-up time, sleeping time, regularity of the schedules, behavior during the nocturnal arousal, use of toilet, eating, drinking, daytime functioning, daytime sleeping, cognitive abilities, drugs and substance use, and other sleep-related problems like maybe obstructive sleep apnea, restless motor leg syndrome, sleep-waking cycle, or any other psychiatric disorder or medical disorder need to be known. Now let's move into the component of CBT I. Before we move, you need to know, are you treating only the CBT for insomnia, or else there is a secondary illness is also there. For example, if a person has severe panic disorder and also has sleep problem, you need to treat both. That means you will be treating by medication panic disorder and cognitive behavioral therapy for insomnia, or else you can use cognitive behavioral therapy for both panic disorder and also insomnia. But we need to ensure that we are going to treat both. You are not going to address, by treating panic disorder, insomnia will go. No. Many a time, insomnia can be an independent illness and it can be the main reason for refractoriness for panic disorder. Hence, we need to treat both. That we have to understand. There are 5 components of cognitive behavioral therapy for insomnia. First and the foremost is cognitive therapy. Second one is sleep restriction. Third one is stimulus control. Fourth one is sleep habits or sleep hygiene. And finally, relaxation techniques. Let's discuss each one of them. First, when you start, better to do a sleep hygiene education. This is general recommendation related to environment, physiological factors, behaviors and habits that promote sound sleep, and also the factors which impair sleep. Specific instruction including advice on control of the bedroom environment, including avoiding visual stimuli, access to clock, not to have a clock in the bedroom, regular sleep scheduling, avoiding daytime naps, limiting alcohol, caffeine, nicotine before bed. So these sleep hygiene education need to be done to the client. So let's look into each one of them. First one is sleep routine. How is the routine sleep? Is there a requirement of any modification? Number of hours of sleep, and you have to recommend at least 7 to 9 hours based upon the age. Whether he is able to fall asleep immediately. If he is unable to fall asleep within 20 minutes, you need to leave the bed. Unplug all electronic items, not to use mobile phone or TV at least 1 hour before the sleep. Look for the mattress and pillow, whether it is comfortable or uncomfortable. You need to emphasize for prioritizing sleep. Further, gradual adjustment with regard to sleep. That means giving priority and planning to go to sleep. Reducing the naps in the afternoon. Winding down, that is maintaining the ritual before sleep. Having a cooler temperature, which will help you to go to sleep. Having dim light. Being relaxed. Doing some amount of physical activity in the evening. Wake-up schedule to be maintained. Reducing the noise in the bedroom. Avoiding smoking. Avoiding any stimulants after 5 o'clock. Block the lights. Limit the caffeine or any stimulant. Avoiding eating too late, eating too much, and also if there is obstructive sleep apnea, one need to think of getting treatment for OSA. So these sleep hygiene important points need to be educated, and if they have a chart, that should be maintained. The second one is stimulus control. Here, this is a behavioral instruction aimed at strengthening the association between the bed and the sleep. Unfortunately, in insomnia, the bed has an association with being awake. Hence, we need to break the association between the bed and the wakefulness. Hence, the recommendation for stimulus control is to break the association between the bed and wakefulness. We need to give a clear-cut prescription. Use bed only for sleep and, if required, for sex. Otherwise, bed should be for sleep only. Many a time, many therapists will say, use bedroom for sleep only. It should not be used for any other purpose. Going to bed only when we sleep, when we feel sleepy. If you are unable to sleep between 15 to 20 minutes, get up, go to other room. That's the clear-cut prescription has to be done. This is why. This is because of the association. That is Pavlov's experimentation of classical conditioning. What does it mean? Before conditioning, an unconditioned stimulus like food causes salivation in dog. Later, pairing the bell with the food for some time, which causes salivation. Now, just bell ringing causes salivation. So here, a person who has insomnia is sleeping on the bed and is wide awake, thinking, becoming anxious, becoming dreaded. That means there is an association has been developed between the bed and being awake. Hence, the association between the bed and these factors, being awake, arousal, anxious, preoccupation, rumination, worry, dreadfulness, and restlessness. This association need to be broken. The bed should have an association with sleep and maximum sex. The bedroom should be used only for sleep. Don't use the bedroom for any other purpose. That is very essential for stimulus control, my dear friends. So, the good stimulus control clearly shows that bedroom is used for sex and sleep, and stimulus discontrol, using bedroom to eat food, read there, watching TV, working in the bed, worrying in the bed, resting in the bed, and various other purposes. This causes stimulus discontrol, and the association bed with being awake becomes paired, and this causes classical conditioning. Hence, we need to break this association, my dear friends. Hence, use the bedroom for sleep only. And if you are unable to sleep within 20 minutes, move out of the room, go to the other room. Either you can read, engage in relaxing activities. And once you feel sleepy, go back to the bedroom. So that is what is called as stimulus control, my dear friends. Now let's move to the third, sleep restriction. Sometimes it is also called as paradoxical intention. What is sleep restriction? Here, it is a behavioral instruction to limit the time of sleep. So by limiting the time, you are increasing the drive for sleep. What is paradoxical intention? Here, you are not limiting. You are telling the client not to sleep. Paradoxical intention, because here the person has developed the habit of thinking I am not getting sleep. Here he is going to sleep thinking I will not go to sleep. I'll be awake. So that is paradoxical intention. Although both appears to be same from behavioral terms, but the principle they are different. But however, the sleep restriction is the one which is allowed across the world, and some of them also use paradoxical intention with regard to cognitive restructuring. Here, the time allowed in bed is initially restricted to the average perceived time of sleep per night. Imagine the person says, I sleep only for 4 hours. then you fix that 4 hours or 5 hours. That is the amount of time allotted for him to sleep, and the rest of the time he's not going to sleep at any cost. He will be awake, and he will be giving that sleep window to sleep only for that 4 to 5 hours only. Let me give an explanation. This is the time 10 p.m. to 6 a.m. You can see in the bottom. The normal sleep starts at 10 p.m. and he wakes at 6 a.m. In difficulty in falling asleep, you can see he's awake till 11:30, and also early morning he gets up at 5 o'clock. Fragmentation of sleep, you can see here is every 1 hour is awake. That is fragmentation of sleep. Now in this scenario, both in difficulty in falling asleep and break in sleep, you need to ask, what is the perception that amount of hours he's sleeping? He may say 3 hours or 5 hours. That 5 hours need to be fixed now. How to fix that? Again, 10 p.m. to 6 a.m. The perceived sleep is 5 hours. So you need to look at what is the peak time he sleeps. So he is awake till 11:30 and he is able to sleep up to 6 a.m. and there is a break in sleeps. So what you will do is we'll fix the timing of sleep now. You are not allowing him to sleep from 11:30 to 6 a.m. Here you will give only 5 hours of sleep. That is between 12 to 5. No sleeping, no nap or no rest in the daytime. The sleep window is between the time given from 12 to 5 a.m. That is very, very clearly given. Here the focus is on the quality of sleep for next 1 to 2 weeks. You're not talking about the quantity of sleep. You have to educate the client, telling that in the long run this is very essential. First, let's have a good sleep drive. For that, you'll be sleeping only for 5 hours from 12 a.m. to 5 a.m. That window need to be fixed, and in the rest of the time is not going to sleep. That is called a sleep restriction, my dear friends. So by doing this over a period of after 2 weeks, what you will do? You are now going to increase the time from 5 hours to 5 hours 15 minutes. You will be preponing by 5 minutes. That is, maybe if you are giving for 12 a.m., you will make it from 11:45 you will go to sleep for next 1 week. That means by sleep restriction was there for 5 hours. Now you will make it allowing him to sleep more by 15 minutes. That is 5 hours 15 minutes he will sleep. After 1 week you will make it 5 hours 30 minutes, 6 hours. Slowly you will increase. By doing this, the quantity of sleep also increases. Here, we are focusing more on quality of sleep first and later quantity of sleep, and we are consolidating the total sleep during that window period of time, avoiding the daytime nap, daytime sleep and daytime rest. Why do we do that? There is a clear-cut understanding. We need to get the maximum benefit during the window period, having the drive period, and having maximum sleep during this melatonin release. That is the time we need to fix, and it depends upon the person to person. It can be between 11 p.m. to 6 a.m. So based upon the individual, you need to fix. And that's the reason we need to have that sleep restriction, which has been found to be very effective in cognitive behavioral therapy for insomnia component. Now let's look into the fourth one. What is cognitive therapy here? Here the aim is to identify, challenge and replace the dysfunctional belief and attitudes the client has. Such misconception will lead to unrealistic thinking and expectation, fear of missing out on sleep, overestimation of the consequences of poor sleep, may have cognitive distortion. Cognitive distortion such as maximization, minimization, all or none phenomena. So these kind of things needs to be challenged. How to do that? Let's look into this diagram. There is a situation in the evening. He is doing work. He feels tired. But even in the 2 a.m., he is awake. What are the cognition he has? I really must get some sleep. If I don't sleep today, tomorrow I will have a very bad day and I'll not be able to work at all. This causes anxiety and sadness. And hence he will go to bed very early and he will be awake in the bed. He may also think, I might get sick if I don't sleep. I will have a very bad headache. And this causes again anxiety. And he will be in the bed till the day in the tomorrow. So this kind of cognitive thinking, rumination, becoming anxious and dreaded causes insomnia. Thinking like that. Example, I will never fall asleep. You need to replace it with, I will eventually fall asleep. Some patients may say, I'm going to be miserable if I don't sleep for 8 hours. You need to replace that. I have survived all these days with minimal sleep. I will survive tomorrow also. I am so frustrated. I can't sleep at all. You need to replace this. This is a hard moment. This is painful, but still I'll be able to overcome. That kind of thinking process brings down the frustration, anxiety, sadness, dreadfulness. He becomes calmer and cooler. By doing this, he'll get relaxed and he'll be able to focus on sleep. Hence, we need to now think about relaxation techniques. Here, relaxation techniques can be any technique which limits the cognitive arousal and decreases the muscular tension. This can be, relaxation can be done by yoga, meditation, mindfulness, progressive muscular relaxation, guided imagery, or breathing techniques. So any of these things which can be used for relaxation, it can be any of them. And the cognitive arousal, physiological arousal, if you are able to get control, then insomnia can be defeated easily. And finally, the relapse prevention. By doing relapse prevention, you will be revising all the 5 components. You will give homework assignments. You will keep the sleep diary for documenting sleep and awake time. Quantity and quality of the sleep will be documented. 2 to 3 booster sessions can be done over a period of next 6 months. What are the dysfunctional beliefs? And that needs to be challenged. So these are the 5 techniques, and 6th one is basically relapse prevention, which can be focused. So these are the various components of cognitive behavioral therapy for insomnia. Now the question is, which component of cognitive behavioral therapy is very effective? This diagram clearly says that limited evidence is there for sleep hygiene and cognitive therapy. Moderate evidence is there for relaxation, light and dark therapy, and paradoxical intention. Unfortunately, light and dark therapy has been now abandoned. Relaxation and paradoxical intention is considered. The strong evidence is there for knowledge about insomnia, sleep restriction, and stimulus control. Let's discuss about how to plan the CBT sessions in the clients. Here, I have talked about 5 sessions. The first session, you will be talking about sleep education, sleep hygiene, and stimulus control. Session 2 will focus on sleep restriction therapy. Session 3, cognitive therapy. Session 4, you will be talking about progress and obstacles, focusing more on cognitive therapy. And finally, relapse prevention. So invariably, you require 6 to 8 sessions face-to-face in cognitive behavioral therapy for sleep, my dear friends. Now let's look into what are the specific instructions to be given to the patient during cognitive behavioral therapy. As I mentioned, we have around 5 important components, that is sleep hygiene, stimulus control, sleep restriction, relaxation, cognitive, and finally the relapse prevention, or also you can call it as wrap up. Let's look into each one of them. In sleep restriction, in the end you can see in the top specific direction given to the patient. Here you will tell sleep restriction means reduce the time in bed. The perceived duration of sleep, that is 5 to 6 hours, only be given as a window of period for sleep. Hence, you need to ask him to choose a specific hours on the basis of personal preference and circadian rhythm. You will allot the time, and the patient also will be contributing, and by collaboration you will be choosing the specific time to sleep. That is the window period of sleep. Remaining time he is not going to sleep. You need to discuss with the patient and tell him. In sleep restriction, this has to be done. It is difficult to getting sleep, but early morning, since he has not slept, he will sleep for longer duration. Hence, he need to make efforts to get up early. That is the time given between like 12 a.m. to 5 p.m. 5 a.m. is the time given. He needs to get up at 5 a.m. at any cost. In the long run, this is essential. He should not say that I have not slept. I have slept only for 2 hours. I'll sleep more time. That will cause again an imbalance. You need to get up at 5 a.m. means he has to get up at 5 a.m. That is called a sleep restriction. Moving to stimulus control. Here, you need to give a clear-cut prescription that if he doesn't get sleep within 15 to 20 minutes of being in the bed, he needs to get up, move out of the bedroom, do some activities which relaxes him in the other room. Cognitive therapy. Maintain a reasonable expectation about the sleep. Review the diary. Challenge the fear what he has with regard to sleep. Relaxation. It can be yoga, it can be breathing exercise, meditation, which relaxes him should be done. Sleep hygiene. Limit the caffeine intake, alcohol intake, limit the liquid intake after 7 o'clock so that he should not get up frequently for urination. Remove the bedroom clock. Remove the bright light. Not to get exposed to the phone or the TV. Now the question is, how many number of sessions are required? As I mentioned, weekly one session, 4 to 6 sessions is maximum, 45 to 60 minutes per session. Face-to-face therapy, it can be there. Telemedicine, hybrid, both in-person and digital or digital alone. 2 booster sessions can be considered. When you are treating a secondary insomnia, treat both the primary and the insomnia. That means you will attack the comorbidity also. You will not ignore insomnia. You will treat insomnia by CBT I, and the primary illness can be treated with medication, or else also the psychotherapy can be considered. What about the hybrid approach, sir? As I mentioned earlier, majority of the patient receive medications first. By the time when they reach the psychotherapist or the psychiatrist, he will be on multiple medications by the general physician. Can we start CBT I now, or should we taper off the medication? I usually prefer to start CBT I along with the medication. Don't stop benzodiazepine abruptly. This will cause severe withdrawal if he is for longer duration. He may throw a seizure. Hence, we need to taper the benzodiazepine and also start cognitive behavioral therapy. Hence, no need to stop medicine abruptly. Start tapering the medicine very slowly. During that period, the client can learn about the cognitive behavioral therapy skills. You can educate him about the sleep hygiene, discuss about the slow tapering of medications. By doing this, you are withdrawing the medicine slowly and introducing cognitive behavioral therapy. But you need to remember, cognitive behavioral therapy for insomnia, 60 to 70% of the patient will benefit. Still, there are 30% may not benefit, for whom medication can be required, or else combination of both CBT and medication may be required. Is there a need for sleep diary? Yes. For simple reason, there are many studies which clearly said, if the person is able to do homework assignment and able to do diary, that is directly proportional to the improvement. Hence, this kind of diary can be kept regarding at what time he got up in the morning, what are the activities he did, how long he was in the bed, what were the thoughts, what were the feelings. Similarly, in the night, he has to record every day. By doing this, you'll be able to understand the client's thinking process, his emotions, his behavior, his sleep habits. His sleep hygiene habits can be monitored for at least 1 week. From there onwards, you will be monitoring and doing cognitive behavioral therapy. Another important question is, can we use technology for insomnia? Of course. You can use actigraph, that is wearable devices. Nowadays, various smart watches are available, along with the apps which will monitor the activities of sleep in the night, so you'll be able to understand how much the person is sleeping and moving. The next question is, who should do cognitive behavioral therapy for insomnia? Is it only the psychiatrist? No. There is a study which was published in journal Sleep Research in 2023. Janelo and Blom published this important article which discussed about training of professionals in cognitive behavioral therapy for insomnia, a systematic review of peer-reviewed studies. What did they conclude? This peer review revealed there is a little training currently provided across studies with regard to cognitive behavioral therapy for insomnia. They recommended digital training to be given. At this point of time, insomnia is becoming a public health crisis. Along with this, benzodiazepine use and misuse is also becoming a menace. Hence, the author said that cognitive behavioral therapy for insomnia for everyone was the call. Hence, we need to train all healthcare professionals, all physicians, primary care physicians, specialists, social workers, nurses, psychologists. Hence, to move this field forward, we need to have high quality studies with regard to CBT I training. And also, the outcome need to be measured. Further, the professionals which are to be trained is from the primary care doctors to the technicians. For simple reason is, insomnia is becoming a public health crisis at this point of time. How to plan for secondary insomnia? For example, here person has a migraine and also insomnia. Because of migraine, he has a poor sleep hygiene. This causes anxiety, insomnia, and again migraine attack. So here, the physician need to treat both migraine and insomnia both. You need to attack from both the ends. You cannot think that by treating migraine, sleep will improve. No. Many a time, migraine has 30 to 40% of the patients also has insomnia, especially if it is a chronic recurrent migraine attacks. Hence, we have to treat both the migraine and also insomnia. It may be any other illnesses which is comorbid with insomnia. To conclude, my dear friends, in CBT for insomnia, there are 5 important components: stimulus control, sleep restriction, relaxation training, sleep hygiene techniques, relapse prevention, and also cognitive therapy, my dear friends. Many patients do not receive proper diagnosis of insomnia at this point of time in our community. Often primary care doctors, general physicians, and many other medical professionals are not trained in sleep medicine. They do not get educated with regard to cognitive behavioral therapy for insomnia. It is not only with our medical profession, but also with the allied healthcare professions such as social workers and psychologists. They are not trained in sleep medicine, and many a time, very few get trained in cognitive behavioral therapy for insomnia. Many of the patients with insomnia receive medication, that is sleeping pills, invariably irrational prescription, misuse, and overuse of sleeping pills are very well known across the world. and it itself is becoming a public health crisis. Often, CBT professionals are also not trained in sleep medicine and insomnia. There is lack of adequate trained manpower across the globe with regard to CBT. Hence, there is a need of massive training of professionals, all healthcare professionals, allied healthcare professionals in cognitive therapy, cognitive behavioral therapy for insomnia. These are the various self-help books which can be given, advocated to the clients. My favorite is Say Goodnight to Insomnia, the 6-week program by Jacobs. Further, Quit Your Mind and Get to Sleep, Somni Skill Workbook. These are the self-help books which can be advocated to the clients. Further, there are certain apps which have been available in the market, and only 2 of the apps have been approved by the FDA. One is Somerist and SleepYourX. Both are being tested for their efficacy. Hence, FDA has approved them. Unfortunately, these are the apps which have to be prescribed by a psychiatrist for use, which are not easily available in your apps to be downloaded. Hence, you need to contact the psychiatrist for insomnia to get these FDA approved apps. There are various other apps available, Sleepio, Shruti, CBT I Coach. These are available online and you have to pay for the subscription. Thank you very much for giving your valuable time. Stay safe.